All right. Welcome, everybody. It is the top of the hour, and we're going to go ahead and get started. To all of you, our many guests across a number of time zones, good afternoon, or maybe it's good morning. My name is Emily Eberly, and I will be your moderator today. Welcome to our webinar. On behalf of Covidian, I want to thank you for joining us for our Improved Monitoring, Improved Outcomes webinar series. By attending this webinar or by watching the video on demand, you can earn 1 contact hour of CRCE and CNE. At the end of this webinar, you can obtain those continuing education credits by logging on to www.sextesting.com/INIT. And then you'll complete their post-test and evaluation form. And upon successful submission there, you will be able to print your certificate of completion. This educational module was made possible through an unrestricted educational grant provided by Covidian. And unless cited, the contents and conclusions of this course are solely those of the course provider. Speaking on this very important and timely topic today of common, costly, deadly, and post-operative respiratory compromise is Dr. Ruben Restrepo. Dr. Restrepo is professor and director of the Bachelor's Degree Completion Program in the Department of Respiratory Care at the University of Texas Health Science Center at San Antonio, Texas. Trained in medicine in Medellin, Colombia, Dr. Restrepo has achieved academic positions at Georgia State University and then also at the University of Texas. He has published a wide variety of articles and book chapters in the field of respiratory care and has given many presentations. He is a reviewer for several major journals in respiratory and pulmonary medicine and is the recipient of many honors and awards for his teaching, publications, and volunteer work. Dr. Restrepo discloses that there will be no conflicts of interest associated with this presentation and the following. He is on the Medical Advisory Board and is a speaker for Teleflex Medical. He is an investigator and speaker for Covidian. He is on the Advisory Board for Salter Labs. He is an investigator and speaker for Fisher & Paykel, and he is also an investigator for Hillrom. Furthermore, there will be no off-label use mentioned for any products discussed in today's webinar. Dr. Restrepo, it has been a real pleasure working with you as we prepared for this event. Are you ready to begin the presentation?
Yes, I am. Thank you, Emily, and thank you, everyone, for attending this webinar on this very important topic of post-op respiratory compromise, realizing that it's a common entity, is very costly and deadly. What I have selected for my learning objectives today would be to define, of course, the post-op respiratory compromise and its overall impact and review some of the current recommendations to prevent it. What I have selected as my outline to achieve these objectives will be I will review some of the epidemiology associated with the post-op respiratory compromise. I will describe also its overall clinical and financial impact, list some of the risk factors, of course review some of the existing guidelines on respiratory monitoring, and finally provide some recommendations to reduce the post-op respiratory compromise. I think it is always useful to define some terms, and I think when we speak of post-op respiratory complications, we are really truly looking at the overall perioperative portfolio of situations that can arise to patients, both with and without risk for complications. In reality, we should call the first entity more perioperative respiratory complications. Post-operative respiratory compromise is ultimately a result of a post-operative complication that really goes beyond pneumonia and atelectasis and encompasses more the degree of respiratory insufficiency that sometimes we see in the impending respiratory failure in the units, respiratory failure, and even cardiopulmonary arrest. I think it is therefore very critical to recognize that both recognition, prevention, and also the management of this post-op respiratory compromise that really relies on vigilance that is exerted by clinicians taking care of patients undergoing procedures that may appear routine and uncomplicated. One of those examples may be, again, procedural sedations. How many of us will probably attend to a bronchoscopy suite to really help with the procedure, or how many of us have gone through, again, procedural sedation that deals with a simple GI procedure such as endoscopy. More and more of these procedures are performed outside the operating room, but then again that put the patients at risk for respiratory compromise. As you see on the following slide, there's a feast of symptoms, lab values, and different signs that could be associated with post-op pulmonary complications. So they are, if you go down the list, I'm not going to just read all of them to you, but I think it's quite clear that some of these are going to be very vague. So as much as we would like to pinpoint the signs and symptoms of the post-op pulmonary complications, these may be, again, indicating many other entities. As you can observe from the list, there are a myriad of both, again, subjective and objective data that just simply tells us something is wrong. So that means that probably careful observation of the subtle signs may be the key to really unveil sudden changes in patients undergoing, again, as I mentioned before, procedural sedation or general anesthesia. I believe that sometimes to really understand how critical an entity is to review how often a clinical condition is present or how often it appears. The incidence of post-op complications has been reported as you can see, with a wide range that could vary from 2% to as high as 40%. However, the most common reported incidence is the one that occurs on 1 on every 8 procedures, and in some institutions it may occur twice as often as post-op cardiac complications. So when you look at now the post-op pulmonary compromise, it has even a higher incidence than that of sepsis, which is actually very critical. When it comes again to respiratory depression, the incidence is still very high. Agarwal in this report that you see in number 5 clearly states that and has anticipated that unless monitoring becomes more rigorous, the incidence of respiratory depression will actually increase to these alarming numbers that you see, 1.3 million cases, or again a 31.6% increase, which is going to be quite unacceptable if we speak of such increase for entities such as COPD, diabetes, hypertension, and so on. So in this study by McAllister between 2001 and 2003, they opted to analyze over 1,000 surgeries where 28 of those patients suffer from post-op pulmonary complications within the 7 days of the surgery. Although, as you can see, one patient died in this series, the length of stay was significantly higher, an average over 20 days longer than those patients without any post-op pulmonary complication. So that imposes, again, the risk for patients who remain in the hospital to acquire more infections. And not only these days where we have a cap for every single admission, when it is predicted in this particular case that without complications, insurance are going to be paying only 4.5 days, and the remaining of the stay is going to be responsibility of the institution per se, without being able to claim any cost. In this table by, again, McAllister, I think what I wanted to highlight is the importance of some of those risk factors. So what is about the patient, what about the preoperative state that could increase the risk of those situations? As you see on this column of the odds ratios, at the end it will indicate the number of subjects, and of course the odds ratio will indicate how many times, again, the risk increases the chance for post-op pulmonary complications. It is quite obvious when you look at the perioperative nasogastric tube, even though the number of subjects included in the studies is not as large as the one you can see for some of the pulmonary complications, is quite high, as about 13.5-fold increase in the post-op complications. And then it goes down to situations where you have age being a factor, typically again greater than 65, 70 years of age, and some other factors that are highly related, about 5 times higher risk, is when the surgery lasts at least 2.5 hours. in regards to the number of subjects that have been included in studies with some very specific respiratory situations like cough test, heavy smoking history, COPD, when you have, again, a pattern of airway obstruction or daily productive cough, again, increases the chances for post-op respiratory complications up to, again, 4.2 times or 4.3 times. Instead of just, again, boring you with detail about the percentages, what I wanted to show you is demonstrate the key word here is that even though there's some evidence, the evidence is relatively fair and poor. I wanted to leave you with the message that even though, let's say, we try to, in a sense, treat or prevent the best way we can with lung expansion therapy, pretty much by just doing in-center spirometry, deep breathing exercises, early mobilization, and CPAP, the reality is that the evidence is relatively poor and it is not very consistent, which can be highly demonstrated by just the following just few slides that I'm going to display in a minute. If we were to look at the overall impact of PPCs, what we'll have to say, and I'm going to give you more detail about this, is that when you have a patient with PPC, there will be increased morbidity and mortality. There will be, of course, increased length of stay. It will be much more expensive, and typically it will just lead to lack of rapid identification. So you can go both ways, either because you lack recognition of PPCs or because, again, more situations may arise and that could make a post-op pulmonary complication, a post-op respiratory compromise with, again, respiratory insufficiency, arrest, and failure. What about the clinical burden? I think when we measure clinical burden, we try to determine exactly if those patients have a higher degree of morbidity, mortality, health resource utilization, before we even look at the financial numbers. I think it's quite clear that it's been widely reported in the last few years, the impact, again, from 2005 to these references that are very fresh in 2013, that is a 300-fold increase in the 30-day mortality. So that means that just beyond looking at very specific abdominal reconstruction and so on, you can see that even those patients who make it to the ICU, they continually suffer from failure to wean versus those who are complication-free. When you look at the 30-day mortality, there's a dramatic difference, a 27% difference between those who fail to wean and those who are complication-free patients. The 1-year mortality doesn't change. It's just roughly about greater than 40-some percent, and the 5-year mortality is, again, twice as much. You see, the reason why I wanted to emphasize these readmissions is because I think it is quite clear the healthcare policy has evolved to avoid unnecessary readmissions. So typically the ones that happen in the 30 days, I think we are going to be heavily affected by, again, the one that is coming up this fall in regards to COPD and the number of readmissions that happen and occur on these patients. Well, it just happens that anytime you have a patient with the post-op complication, there's a good chance that the patient is going to be readmitted 30 days after, and the clinical institution is not going to be covered for this. Not only this, if you're thinking about cost, but 87% reduction in the median survival in patients with PPC. So there's a good chance that if a patient presents to the operating room with or without any risk factors for post-op pulmonary complications, there's a good chance that this patient may die. Not only, again, at this point, thinking of atelectasis, delayed weaning, reintubation, pneumonia, but also, again, as a precipitating cause of cardiac arrest. When you look at this statistics from the Agency for Healthcare Research and Quality, I think it's quite clear, again, a few years ago, that is one of the 5 conditions resulting in the most rapidly increasing hospital costs for Medicare covered stays in the U.S. If you look at the inpatients coming with respiratory insufficiency and arrest, they originate on the floor, and when they come to the floor, they have a much higher mortality rates than those patients who do not present with any risk of insufficiency and acute failure. Again, a difference of 33% and so on. So I think it's clear that many institutions have been paying attention to the fact that the post-op respiratory failure, you call it post-op respiratory complication or pulmonary complication or respiratory compromise, is high in the agenda, is a high priority. But of course, everyone just talks about length of stay, complications, clinical complications, and symptoms. But I think we also have to realize that this is a very expensive proposition. I think it is quite clear that in this particular case, we have learned from looking at, for example, ventilator-associated events or ventilator-associated pneumonia, that if it costs about $40,000 per patient, so now you're looking at attributable cost of this post-op pulmonary complication that could be as high as $52,000. The cost, again, regardless of how much it varies, just realizing that it could cost up to $23.5 billion is again something that is costing a lot of money to the health system. In 2007 alone, it cost about 7.27 billion. And again, this is just because even the smallest percentage that you can have on the post-operative respiratory compromise could cost a lot of money, because typically those patients are going to be much more severe than those that get treated for a simple post-op pneumonic process or post-op atelectasis. As I mentioned before, the statistics go all over the place depending on the study. In this particular one by Wire, in this June of 2010, this brief number 91 from the Agency for Healthcare Research and Quality clearly shows that 2 days longer than any cardiac complications. So it is again the impact or the price that you have to pay for having a post-op complication is very high. And of course, when you look at the length of stay, even though it's again 2 days longer than cardiac complications, is going to be significantly higher in the ICU and the hospital when you compare those patients who present with, again, respiratory compromise, insufficiency, and failure compared to those patients who have no issues. I think we always want to recognize these patients. I think it will be very wise to know, okay, what are we about to encounter? What type of patients do we have? And I think it is clear that if we call this issue to be perioperative, we have to look at, again, the pre-operation, the intraoperative, and the post-operative period. So when you look at the preoperative, you look at age being a factor. Again, it goes all over the place depending on how the research has been done. Richard Branson summarized these factors very well in one issue of respiratory care last year, looking at, again, age over 50, the American Society of Anesthesiologists, class number 2, which is actually a very mild comorbidities. It can go all the way to 5, where you have severe comorbidities, liver disease, CHF, cancer, COPD, cigarette use, obesity, OSA, impaired sensorium, corticosteroid use, and alcohol use. And I'm probably just probably guess that you have seen patients with all these comorbidities, sometimes even at once. What about the intraoperative? I think we look at one of the risk factors reported by McAllister to be surgery longer than 2.5 hours. So again, you see the number again, 2.53 hours. When it is done, of course, emergently. When you have blood transfusion, every time you apply general anesthesia, you again increase the chances for these complications to be much higher. When you have the use of neuromuscular blocker agents, which is in fact has been dramatically reduced over the last decade, even if you want to use it in the first 48 hours of patients with ARDS, and always the type of surgery will be instrumental in determining the degree of the incidence of complications in the post-op period. That's why you see in most instances the upper abdominal surgery appears to be one of the most significant factors to cause respiratory depression or respiratory compromise. If you look at the highlight of those post-operative patients, you will have to include those with advanced age, with organ system dysfunction, those who actually have altered mental status or decreased level of consciousness, and I'm going to mention that a little bit later on, or those who have chronic opioid tolerance, because it's going to be much more difficult to manage pain on these patients, and they will typically require a much higher dose. These are not going to be the opioid naive patients where the typical protocol can be followed, followed with a significant change or a significant decrease in the complications in the post-op period. Those patients are going to be having a dose effect relationship between, again, the opioid and the respiratory depression. Obesity has been mentioned on pretty much every single work that I've seen related to post-op pulmonary complications. And I think the key is to understand that there's different degrees, and this is typically based on mass index. So body mass index over 30 has been classified clearly over 25, but if it is 30, 40, and even over 50, of course, the chances for those patients to have post-op complications is going to be much greater. When you look at now at the anesthesia procedure, I think it is clear, it's clear to all of us that in the presence of anesthesia, I'm sorry, just moved too fast, the OSA is extremely critical, and the reason for that is because it is calculated that between probably about 80 to 90% of the cases have not been diagnosed. So the fact that it is clearly diagnosed in 2% in women and 4% in men is completely underdiagnosed. We know that this is the reality of many diseases such as COPD that is completely underdiagnosed or non-diagnosed. So the way we deal with COPD is, of course, by teaching ourselves and teaching providers to make sure that pulmonary function is being evaluated, and of course, a very strong history, a very strong interview, allow us to see or allow us to have the ability to diagnose this more often, so we can actually just manage. So it is exactly the same case with the respiratory compromise. High prevalence of OSA after surgery, usually due to narcotics, and something that is very clear to recognize is that those patients with OSA, but I would say in general, they have a much higher risk of post-op pulmonary complications and respiratory compromise in the 48 to 72 hours following the surgery. And the typical reason for this, as you can see here, is because typically less monitoring happens. I reviewed a case recently of a patient who died at 41 years of age because, of course, typically less monitoring happens. 24 hours without any oxygen, saturations were fine, and the patient died only 2 to 3 days after, just because of the opioid-induced respiratory depression. Patient complains of less pain, increased sleep patterns, and then what we can see with saturations of, let's say, 88, 89, 90% in a patient who's breathing about 6 to 8 times per minute should not be interpreted as normal. Again, unfortunately, we just let this guard, or we are less cautious about these individuals once the 48 to 72 hour period has simply elapsed. The opioid usage, we know that they are respiratory depressants. Either they work over the chemoreceptors or the central receptors in the brain. They will typically, again, cause the central respiratory drive to be depressed. And this is one of the reasons why, again, sometimes anesthesiologists are desperate to call the pain the fifth vital sign, because sometimes it is not optimally managed. And one of the reasons, of course, is because the fear that respiratory depression may occur after the administration of any agent that we need to use for post-op pain. What typically happens anyway when we have typically moderate sedation or general anesthesia or extreme use of opioids is that there will be a decreased cortical response. So there is lower drive. Of course, we will lose muscle tone. The patency of the airway gets compromised, and then you have, again, suppression of neural and muscular activity that reduces the response to asphyxia. So there's a much lower chance for this patient undergoing either heavy sedation of anesthesia to respond in the presence of this depression. So how do we go about reducing PPCs? I think it's been quite clear that we have established some measurements, and I think the key of the management of PPCs has been reduced to manage, for the most part, atelectasis and pneumonia. So that's why the bulk of what you see in the literature, very well summarized by Lawrence in 2006, is that in-sinus spirometry, EPB, IPPB, deep breathing exercises, CPAP, and so on. But what I wanted to highlight with the square is that even though you had a large number of studies, the real number of randomized controlled trials, that means very well conducted, that could lead us to have a very good evidence, or the strength of the evidence is very limited. So you see, again, roughly 14 out of the almost 200 and so studies. So that doesn't give us, again, a lot of confidence. And when we actually wrote a clinical practice guideline just a couple of years ago on incentive spirometry, we got a lot of replies that were negative because we were, in a sense, killing incentive spirometry. Well, just keep in mind that what we wrote in the clinical practice guideline was the emphasis on incentive spirometry not as monotherapy. When you combine this with, again, deep breathing exercises, CPAP, early mobilization, and so on, you could see the results that are typically reported in the literature, or again by your coworkers. But again, just let me emphasize one thing. And so just by selecting at random one particular study, you see that a large number of subjects have been studied, but still the evidence is strong but poor. That means the evidence is very clear that many of these things actually do not work. That's how you should be interpreting this information. And just a reminder exactly of the levels of evidence, when you look at the lung expansion modalities, again, such as atelectasis, pneumonia, bronchitis, and severe hypoxemia, it's been shown again that there are some of those factors, or some of these therapies that can dramatically reduce this, but typically as a combination, not as monotherapy. Very recently, I think it is very clear, and more than trying to remember the ICOF acronym, is the key: multidisciplinary patient care. I think it is quite clear that if you look at every single component of the ICOF published by Cassidy, and now there's a new, very recent study that came out last month with a different acronym that really applies and gives credit to Cassidy for this acronym. Just combines a few things that many clinicians can do around the bedside: incentive spirometry, coughing and deep breathing, oral care, and sometimes it's being done by therapists, sometimes again it's being done by nursing. Understanding, that means the teaching part of the patient and family. Getting out of bed frequently, and it could be again a role of the RT, it could be a role of the physical therapist, occupational therapist, or the nurse. And head of the bed elevation, which is typical again these days to prevent any type of degree of microaspiration. I just wanted to highlight some of the trends on their data, showing clearly that after the implementation of the ICOF, and even during transition, there's a dramatic reduction in both the risk of pneumonia and also the unplanned intubation. As I mentioned before, this is one of the variables that has been measured in regards to the post-op complications. Patients who, again, undergo a surgical procedure that otherwise will be very simple, and in the presence of a risk factor, it got unplanned. And so one of those issues may be that the patient remains intubated and with a high risk of re-intubation. I would say that really what we need to concentrate on is comprehensive and rigorous monitoring strategy. I think the key is not so much to having therapeutic strategies, but something to prevent. But I don't think we are doing extremely well when we realize that even in this study by Chen in resuscitation relatively recently, 77% of the records were missing vital sign, and it happened that respiratory rate was the least documented vital sign. So that doesn't help when we know, of course, that the respiratory function can be measured in so many different ways. And I'll try to emphasize this sometime next week. But this really delays interventions, because if you're not able to capture any degree of respiratory compromise or depression, I think the chances for you to act on it are not going to be heavily reliant on simply the application of hyperinflation therapy. And if you see something alarming here, is by Kwok reporting this in the Journal of Journal of Critical Care, saying that a median duration delay could be 12 hours, which is again could be catastrophic for the life of patients who undergo procedures who, on top of that, have a much higher risk for developing respiratory compromise. So I think it is quite clear that if we have the tools to detect early respiratory compromise, there will be a more successful use of any type of intervention, call it incentive spirometry, early mobilization, deep breathing exercises, CPAP, and so on. And there's no question that many of these patients who were supposed to be on the floor for a couple of days, or again a maximum of 4 days, as I mentioned before, of course will have a much greater reduction in ICU admissions and the overall stay. So what do we achieve when we have continuous monitoring? I think the key is notification. I think we want to be aware of what's going on around the bedside. This is the reason for, again, remote virtual monitoring to to be just catching up with, again, the technology and the connection, because I think it is clear that we want to be documented. I think the Anesthesia Patient Safety Foundation clearly recommends that we have continuous monitoring, and I think it is clear, at least from them, that both oxygenation and ventilation should be monitored, especially on those patients who receive patient control analgesia, neuroaxial opioids in the post-op period. And if you have, again, patients on PCA, the chance of capturing the saturations of bradypnea are much greater when you combine pulse oximetry and capnography versus only one alone. And the one alone that is being widely used, of course, would be the continuous pulse oximetry. And however, again, we have evidence, I'm going to share this with you, that continuous monitoring pulse oximetry, of course, provides early detection of physiological decline, and it reduces, again, the number of events on ICU transfers, but it will be an incomplete piece of the puzzle when you try to rely just simply on this mechanism. It is clear by looking at the next slide from different organizations such as the American Society of Anesthesiologists, the Anesthesia Patient Safety Foundation, the American Society for Pain Management and Nursing, Joint Commission, and one that I didn't include here is the American Society of Dentists, that have incorporated for the longest time the recommendations by the American Society of Anesthesiologists. May be surprising to you that in regards to the ASA, the continuous capnography for patients at risk for respiratory compromise is not checked, only because they recommend continuous capnography on patients who are on moderate sedation, severe sedation, or general anesthesia, and only will use in the presence of mild sedation when the patients are at risk for respiratory depression. But you can see almost every single box being checked for continuous pulse oximetry, and again, for the most part, in regards to continuous use of capnography. But it may be simpler than that. Again, and I'm going to try to elaborate a little bit more on respiratory rate monitoring next week. But I think it's something that we have to understand is that when we have in more than 50% of the cases respiratory rate not being documented, I think what we have to use is some of the evidence that has been produced over the last few years, especially by Buddhist in resuscitation, that the abnormal respiratory rate is a very strong predictor of in-hospital mortality. So that means that any fluctuations of respiratory rate could be significantly increasing the risk of those patients of dying. To be much more specific, let me just summarize this particular study, again, in Resuscitation 2004. This was a prospective of observational investigation in a 320-bed university-affiliated teaching hospital in Melbourne, Australia. And what they looked at was a numerous number of bedside observations, over 1,500, over 7 months on 564 patients. And this is a very incomplete list of all these parameters that they consider to be abnormal bedside observations. So the list includes about 10 of them, but I wanted to highlight, again, 4 of them. The ones that we typically are able to monitor and continuously monitor, which is the SiO2. In this particular case, it could be the SpO2, less than 90%, which is the most commonly monitored. Tachypnea over 30 and bradypnea, which, by the way, less than 6, is being recognized as one of the criteria for respiratory depression. But also the loss of consciousness is mentioned, the Glasgow-Coma scale of 3. In regards to the incidence, you can clearly see that it's about 8.9 patients, 8.9% of the patients could actually just incur into any of these complications. So what were the results of the study? So they found that the most common abnormal observations were 2. Saturations less than 90%, as significantly higher, 51%, on hypotension, about 17.3. But also they were able to observe that the higher the number of events, the higher the risk of mortality. And by the way, which it was alarming to me to find out, is about 1 out of 4 patients with abnormal observations will die. So it's a very strong predictor factor when you look at these several parameters. Even though you see that the bradypnea was not as prevalent as tachypnea or saturation or hypoxemia or hypotension, is clearly the strongest predictor of mortality. So if you have to pay attention to something in regards to respiratory rate monitoring, it will have to be for, again, a patient severely slowing down to 6 breaths per minute, because there's a 13.7-fold increase in the risk of mortality. Again, with this confidence interval, 95% confidence interval between 2.9 and 64 chances of dying because of breathapnea, in comparison to something that happens a little bit more often, not exactly as often as hypoxemia, 51%, but tachypnea, that happens in this series in 6% of the cases, but is correlated with a 6.1-fold increase in the risk of mortality. So I think it is quite clear that respiratory rate is probably one of those parameters that we have a tendency to ignore because it is sporadic. We just monitor this for 1 minute without realizing that, again, is a changing target. So it is not, again, surprising why Barford reported just a couple of years ago, that they found that the strongest predictor of the ICU admission was the patient who was tachypnic, more than 35 breaths per minute. In this particular case, it was not, again, the breathapnea, but the series actually are showing, regardless of how different this data may be, it is clearly showing that monitoring respiratory rate is very critical to determining, again, the risk factors or the risk of mortality for those patients that may be at risk. So what do we have? I think we have typically, again, a way to monitor both oxygenation and ventilation. I think we do a very good job with the pulse oximetry. It has evolved from, again, being able to have so many different probes, so many different sizes, disposables, probes that can be placed in the ear, on the forehead, motion technology, non-invasive oximetry, now respiratory rate-derived pulse oximeter. So we have made major advances. And if we look at, again, what has happened with continuous pulse oximetry and what is the evidence behind using this, there's no question that if you are able to detect saturations less than 90% for at least 30 seconds, you should be able, again, to correct or to reduce the ICU stay and estimated cost just by simple detection. And if you're able to find a system that is very, very smart in recognitions or has a very specific algorithm to minimize the noise that is being caused or the fatigue that is being caused by alarms, there's no question that you can also reduce the ICU transfers and ICU events. The last meta-analysis that I know of is the one published by Pedersen in this Cochrane database system review in 2014, and this is, of course, what they wanted to test. They wanted to see if the use of pulse oximetry was associated with improvement in detecting and treating hypoxemia, if it reduces morbidity and mortality in the perioperative period, if it reduces, of course, morbidity and mortality in all these patients and decreases the length of stay on readmission or both. They mention some implications for practice. One is, of course, that we have a proliferation of monitors in anesthesia. That's kind of just obvious. And even for monitoring devices, we have now a myriad of possibilities. It is probably the same phenomenon that happens with aerosol devices. When we used to have just a simple jet nebulizer and a pressurized MDI, now we have been flooded by just again, a large number of DPIs and MDIs that may, again, make life a little bit more complicated because education about these devices becomes more challenging. So that's exactly the case with monitoring. Of course, it's supposed to allow you as a clinician to have a much more decision-making process, may be more straightforward, and of course to reduce the incidence of complications. However, again, what happens is that maybe you don't have the right monitor, the right response, the accuracy, the comfort for the patient, and so on. And of course, even if you have the best device, you will always have to find the human factor. How rigorous is the clinician looking at this monitors? Is this being just so noisy that now the alarms are always set so distant that you don't hear about the patient, and of course you're going to be missing a lot of information. And of course, again, can pulse oximetry in this case protect against the human factor, which is going to be a much more difficult question to answer. So what they found, of course, based on these meta-analysis, that the pulse oximetry substantially reduced the extent of perioperative hypoxemia. So I don't think it has to be taken out of the equation. Can this be replaced by just simply capnography? I don't think that we can answer this question right away, but I may have, again, some ideas of why maybe capnography may be better than just simply mono monitoring, so instead of just combined monitoring. But we all have, again, different opinions about this. That also, again, enable the detection and treatment of hypoxemia related to respiratory events, so that would be very clear. And I think it's quite clear anyway that we don't even know at this point, even though we have a good impression that continuous pulse oximetry, if this is actually the reason why patients have less complications, and except, again, for the fact that maybe clinicians are more aware when they have pulse oximetry of some other events. So I don't think that has been very clearly studied. So the last piece of the puzzle would be, again, to discuss about capnography. And I think it's quite clear that why capnography is because we are measuring two completely different things. While we measured the oxygen uptake and, again, oxygenation with the pulse oximetry, we were looking at, again, the process of eliminating CO2 by metabolism and, of course, respiration by with the CO2. So we have to, of course, be cognizant of the fact that when we measure respiratory function, we have to look at, again, both O2 and CO2. And this very nice quote from Jonathan Wall, it's clear that when you look at the entitled CO2 or capnography or CO2 measurement, again, it reflects completely different stories. And then the cases of respiratory depression were 28 times as likely as to be detected if they were monitored by capnography as those who were not monitored. So there's a good chance that if you add capnography to, again, pulse oximetry, the chances for you to detect respiratory depression will be much greater. A simple experiment that I conduct with my students by illustrating the point of capnography versus pulse oximetry will be, again, if you hold your breath, what is going to happen? I mean, the beautiful functional residual capacity will be in charge of allowing a free flow of oxygen to the system, allowing pulse oximetry to be sustained relatively okay for the first 2 minutes or so. That is not going to be the situation that happens with the capnography because the waveform will just simply flatten. So I think it will be a much earlier indicator to see changes in the entitled CO2 than looking at just simply pulse oximetry. I think you will probably have a pleasure if you register for this webinar by Dr. Overdijk in a couple of weeks, looking at, again, a series of patients. He has been in the literature quite extensively for this monitoring of patients with PCA that clearly shows that the incidence that we believe happened before, 2-3%, is much higher. So that means it's being able to detect respiratory rates less than 10 for even up to 3 minutes in 41% of the cases, and for 2 minutes in about 58% of the cases, which to me is very significant. This may be all missed. Again, 28 times less likely to detect something like this with only just simply pulse oximetry. And I think, again, just beyond the spectrum of my presentations to go over very specific traces of capnography, but I think it's quite clear, based on the examples that you see, that you can determine, again, rebreathing, apnea, shallow breathing, just very slow respirations associated with the opioid use. So it could be a tremendous tool to help us out. So why not, again, combine pulse oximetry with entitled CO2 routinely? I think when you do that, I think it's been shown by Wong in this particular report, 65% reduction in the overall adverse events, effects and cost. And the only problem that you have, of course, is do you have a system that has an algorithm that filters, for example, coughing, talking, drinking, swallowing, that doesn't get misinterpreted as just a low CO2 that will alarm and will make individuals around the monitor very tired of just listening to this. However, there's no question that when you are going to combine, the preference for most clinicians is to have a single monitor. So I think it is quite clear that when we want to summarize the situation with respiratory compromise, I think we have to remember, of course, that it's common. So it really happens. This is not a 1 in 1,000 patients, but again, it could be 1 of 80 every 8 surgeries that we have. And unfortunately, what could be severe or respiratory compromise, which is again respiratory insufficiency or even arrest, could be as high as 7%. The trend has been, again, very clearly paved by one of the researchers that I mentioned before, that unless we do something, there's going to be a dramatic increase in the rate of the post-operative pulmonary complications. Cost is very simple to just lay down the formula. The more we are able to recognize, the more money we'll save by having less complications and a shorter length of stay. That it could be, again, between 18,000 and 55,000 per case. And the key is that every time we have a patient with a respiratory compromise, the chances for these patients of dying is going to be much greater. So in conclusion, I think it is clear that respiratory compromise is common, costly, and deadly. That I strongly believe that if you look at yourselves and the current monitoring regimens, unless you are doing probably a few of the things that I mentioned, for the most part, even in institutions that I oversee or supervise students, we are just far from being adequate and what it says on number 3, consistent. So it's been shown clearly that the suboptimal monitoring has determined that the rate of post-operative pulmonary compromise and depression is actually higher than we should be. I think it is actually very clear that continuous monitoring of respiratory function is the one that provides us, again, clinicians, the best solution to prevent post-operative compromise. I think it is clear that when we implement the situations of monitoring, we will have patients who actually have less adverse effects, lower, much shorter length of stay, and less overall complications. So this concludes my presentation today. I look forward to having you here next week, next Wednesday, when I will focus on more detailed discussion of monitoring techniques. Thank you for attending today. I will be happy to take some questions in about a minute after Emily makes an important announcement. Thank you again.
Dr. Restrepo, thank you very much, and that was a really informative session. We do want to go through this reminder here that the activity has been approved for 1 contact hour of CRCE and CNE CEUs. And at the end of this webinar, you can obtain those continuing education credits by logging on to www.saxtesting.com/INIT. You'll be able to complete a post-test and evaluation form, and then upon, of course, successful submission, you will be able to print your certificate of completion right there. So, with that in mind, I have a lot of questions. Okay, we have a question here from Jean. We have a physician who does not believe the ETCO2 and wants a blood gas for every high alarm. We are trying to convince him that ETCO's monitoring is a tool and that trends are the value. Any ideas on how we can approach him?
Actually, that's a very good question. If you were to think about one of the main obstacles that prevents CO2 monitoring to be just widespread, it's going to be just the lack of understanding of how entitled CO2 works, and how, of course, if you are working in a cardiac unit with severely or hemodynamically compromised patients, you have to look at this as a tool. Every time you improve your cardiac output, you improve your CO2 elimination. So there's always a gap that exists between the actual PA CO2 and the entitled CO2. The more it narrows, the more it shows that less VQ mismatch you have. For those patients who have no hemodynamic compromise, typically, again, you need validation from your blood gas the same way you will do with a transcutaneous CO2 monitoring or any other tool that you measure CO2. But I think the key understanding is that you just need to validate with blood gases every so often to make sure that the gap or the trend is clearly established. I wouldn't rule out only the capnography or the entitled CO2 measurement only because the gap or the gradient between the actual PA CO2 and the entitled is beyond the 3 to 5 millimeters of mercury that we know of. So I think, again, just being aware of the limitations of the technology doesn't mean that you need to eliminate this when you have a gradient that is greater than the one that is typically accepted.
Thank you, Doctor. Here's a question from Ginger. How does acoustic respiratory monitoring compare to capnography, and does it meet the established standards?
To be honest with you, I haven't used the acoustic, so I don't have a lot of experience to answer the question, and I apologize.
That's okay. Fair enough. Thank you, Doctor. Here's a question from Jean. How do you determine what the alarm limits for ETCO2 should be set to minimize alarm fatigue?
Very, very difficult question. Very good question. I don't think there's a clear recommendation of guidelines in regards, even when we wrote a clinical practice guideline on capnography, I don't think we actually recommended, let's say, a very specific setting because, again, the patient population may be varied. When you have a patient with a very stable VQ matching, when you are monitoring CO2, let's say, in the post-op period for respiratory care monitoring, again, without hemodynamic compromise, I think you could be much tighter because the expectation is that you're going to have minimal changes in the CO2. So having a plus or minus 5 milliliters mercury may be adequate for these patients, but may not be for the patient who has hemodynamic compromise, where you can maybe broaden the alarms, again, 10 and above. I completely understand alarm fatigue. I've been, again, doing studies on ventilator alarms, and trust me, I completely understand why, again, when you have a patient with a peak pressure of 20, the high pressure alarm is 50, but that doesn't mean that it's adequate. I think monitoring devices these days are coming out with very smart algorithms that will allow you to, again, to minimize noise. I know, again, for a fact that some of the companies have, again, this very specific algorithms that allow to minimize noise. So the average of, again, several breaths is actually what is being documented and plotted on a waveform versus every single attempt or just what mirrors every single breath. So I understand fatigue very well. I always tell my clinicians, the ones who I train, is that if there's something that we know about a monitoring device, is that we know exactly how to silence the alarm. We may not know anything about the device, but we know exactly how to silence that. But I think, again, it's just the fact that limitations of technology these days, for the most part, just, again, doesn't allow us to use these very smart systems.
Thank you, Doctor. Here's a question from Shelley. So how do we compensate for abnormal HR or other factors that prevent reliable and accurate SAAT readings?
I think the only answer I can have for you is by knowing the patient. I think there is, again, unless you have algorithms built into a very particular device that allows to correct for that noise, I think you will have to know a little bit more about the patient who has, let's say, for example, dysrhythmias. I would say that many of the devices correct for this, and again, will give you like a 10-second average of those signals. But again, it doesn't apply to every single device. So those devices that allow you to, again, correct for this minimal variance, because you and I will have variability of respiratory rate, and that's why, again, systems will allow you to, in a sense, ignore every single signal. Otherwise, again, alarms will go off, and the intermittent detection of this particular pattern will be, again, not very useful clinically. When we look at trends, we determine, for example, the circadian cycle, and we determine, of course, that variation of blood pressure, heart rate, and respiratory rate will happen over time. It may be again that incorporating to the current monitoring alarming systems, those normal cycles that happen throughout the day may minimize the false alarms. At this point, I don't think, again, except for a few monitoring devices, those systems are not just, again, highly applicable, because it doesn't exist on every single pulse oximeter, for example, that we have, or on every capnographer that we have here in our lab or at medical ICU at UH and so on.
Doctor, thank you. Here's a question from Kimberly. Do you think having RTs completely managing the patient as far as oral care, DBE, IS, etc., will improve the patient's outcome instead of having nursing extensive involvement?
That's a very good question, too. Whoever cares more about those protocols should be taking care of that. Let me give an example. When RTs were given oral care, the only thing I can describe this was as madness, protest. We don't want to do it. Even though it related to something that reads ventilatory or ventilator associated pneumonia, the RT group and this particular institution had a very big issue. I think it is a matter of multidisciplinary efforts. I think it is clear that those who are able to claim, some of you, some of the, again, 1,400 who registered for this, are able to tell that only multidisciplinary efforts have typically resulted in best results for the reduction of VAP, for example. So VAP is a similar monster to respiratory compromise. when you as a team decide that this is exactly the individual or a group of individuals and clinicians who are going to implement this bundle and are going to follow through, that's when you get the results. I don't think it is going to be ultimately just the RT or DRN. It's, again, the more competent for that institution that follows or adheres to the protocol is going to be the most important piece in determining, again, how to reduce these issues, both VAP or respiratory compromise.
Thank you, Doctor. Jenny wants to know, are there specific capnography protocols?
Not that I know of. I don't think, other than instructions how to set it up, I don't think there's a very specific protocol. Again, Brian Walsh and I just recently wrote the clinical practice guideline for capnography, and we recently wrote a paper with Jonathan Wong Pagnushu on respiratory inside or capnography for non-intubated patients. And I don't think we were able to find a very clear protocol. What you can find is, again, recommendations and guidelines. So I encourage you to, again, to start by reviewing the clinical practice guideline from the ARC that came out, again, 2 years ago, written by Brian Walsh and I, on, again, the use of capnography for intubated patients. That's typically, again, a good protocol to start with, but not that you're going to find a clear recipe on how to use it, except for, again, something that is going to tell you, know your patient, know the limitations of the device, and of course realize that you have to be aware of, let's say, waveform interpretation so you make the right decision about your patient.
Thank you, Doctor. Here's a quick question from Sharon. Is there anything new in the future of monitoring for respiratory depression?
I think there is. I think, let me just summarize this because I'm going to mention some of that next week, and of course the week after, Dr. Overdijk is going to be just go over and beyond, again, technology in much more detail. I think you as a clinician could anticipate exactly what you want. I think if you were to ask me why would I want to have, or 15 years ago when I was in pediatric ICU as a therapist, what would I want to do is I would like to have one device that allows me to read everything. It's pulse oximetry, capnography, again, co-oximetry, and so on. So I think combining monitoring into a single device, it's here and it's going to come more often, again, with much more force than what we had before. And I think one of the keys, too, is that there's no question. Let me give an example. A layout for University Hospital at this point is humongous. It's a huge building. By the time you get from the nurse station to one of the patient bedsides, you have lost 2 pounds because there's so much walking involved. So I think the key is that central monitoring, virtual remote, will be also very key, having access as a clinician to be able to monitor this and to have a very nice set of alarms, an algorithm very smart enough to be able to detect that the reason why you're seeing on your phone or your whatever system you have on your iPad, laptop, or whatever it is signaling low priority, medium priority, and high priority alarms. I think that's what, again, the future is actually here. Is not, again, the implementation. The implementation of those devices, those monitorings, again, is far from what maybe sometimes administration is willing to pay, but it's here.
Thank you, Doctor. So here is our next question. It's from Joan. What is the effect of sepsis on POC?
The effect of sepsis is it's increased. The sepsis depend. Well, let me just take two paths here. Sepsis typically has two phases, one that is called the hyperdynamic phase and the one that is hypodynamic. Of course, you don't want to see patients in the hypodynamic because that's the one that patients is about to fail and about to arrest. In the hypermetabolic state associated with sepsis, you realize that CO2s are going to be greater. So that's why sometimes you may see a discrepancy between what you see on the end-tidal CO2 and your actual PA CO2. Or, let me just put it this way, what if you are doing the best to match minute ventilation demands on this patient and your CO2 still doesn't match what you're doing? That's why you have to consider that septic patients increase CO2 demand. Remember that those patients in the ICU are the ones that are going to be more demanding of tidal volume. So if you have a septic patient with ARDS, you do lung protector strategy, and it's been shown that those patients become more desynchronous because they want more of you. There's a very high demand for everything, and the metabolic rate could be, again, exceeding what your minute ventilation is doing, so your CO2 may go up. Understanding of this could, again could help you understand why you see these readings on the waveform and the capnometer too.
Thank you, doctor. This is a two-part question, and we better make this our last. For surgeries lasting longer than 2.5 hours, do you think the airway clearance during surgery would reduce some of the POC? And then part two of this question is, how much does GERDs and abdominal distension contribute to POC?
So let me start with the last one. So GERD, gastroesophageal reflux disease or disorder, heavily contributes to pulmonary complication post-op. In fact, the reason why the nasogastric tube is in place is typically to reduce this. Unfortunately, what happens with the nasogastric is that it increases the chances for aspiration. That's why, again, you have a 14, 17 times higher risk of PPCs when you have nasogastric decompression. Well, nasogastric decompression, no, is the placement of the NG tube. The first one, I don't really understand very well if you have mucociliary clearance or mucus clearance during the surgical procedure. You don't typically incur into any type of technique that incorporates mucus clearance during the procedure. I don't think it's going to be just wise unless it's absolutely indicated for airway clearance if the patient is plugging. For the most part, what you have to realize is that what if you have, let me kind of just rephrase the question, what if you have a patient who merits maybe mucus clearance just to start with before the patient goes to the OR. So that patient will be at a higher risk for a post-op complication, something that, again, I will be able to monitor or determine or detect much sooner if you have the right piece of equipment. And even if you do, recognition and treatment with the right amount of hyperinflation therapy and mucus clearance, maybe the, again, addition of mucolytics and CPAP or PEP therapy, high frequency chest wall oscillation, whatever, again, works on your institution.
Thank you, doctor. And let me just squeeze this one last one in here. Can you comment on if atelectasis causes fever? Did I say that right?
Gosh, that's such a good question. Atelectasis does not indicate infection, but atelectasis can be interpreted as a process of inflammation. Inflammation can actually trigger fever. So that doesn't mean that when you have a patient with atelectasis, that merits treatments that deal with antibiotic therapy. It is only, again, maybe interpreted as an inflammatory process that causes fever, not because every single process of atelectasis means infection.
Thank you, doctor. And we are absolutely at the end of our time limit here.
Thank you so much.
Yes, it was a very, very informative session, and we all learned a lot. The material that you've covered with us today is absolutely vitally important in the care and treatment of postoperative patients. Doctor, thank you so much. And finally, last but not least, I'd like to thank each and every one of you, our guests in the audience today, for your time and your very thoughtful attention. Thank you, take care, everyone, and bye for now.